My name is Helen Bronte Stewart. I'm from Stanford University School of Medicine. And in this presentation, I will be talking about DBS programming with different devices. The most important aspect of DBS surgery is the accurate DBS lead placement. But the choice of target may require different aspects of DBS technology. For instance, here's some lead reconstructions done by Kevin Wilkins in my lab, showing the placement of the DBS lead in this small structure, the subthalamic nucleus. And even within the STN, it's important to place the lead within the sensory motor region of the STN, shown in blue here. Now, another important feature of DBS programming is that as you increase the intensity, i.e. the current or the voltage of DBS, you will increase the electrical field or the volume of brain tissue that is activated or modulated. And here you can see this increasing as we increase in percentiles of intensity up to the clinical voltage or current being used. For the subthalamic nucleus, this means it's quite easy to encompass the sensory motor region, but it's also quite easy to encompass regions outside the STN that you may not want, and this may lead to adverse effects. However, the sensory motor region in the globus pallidus interna, or GPI, is much larger and a more irregular volume, and so might require different aspects of technology. And in the thalamus, there may be multiple targets for tremor, which again may lead to using different technology. So I'm going to discuss the use of directional leads and shorter pulse widths in the subthalamic nucleus for treating Parkinson's disease with DBS. And it's true that a well-placed concentric lead or the use of a directional lead in a ring mode may provide optimal efficacy. Clinical efficacy was not improved using directional leads when the electrodes were within the desired STN region. But those even slightly displaced, 2.3 millimeters compared to 1.5 millimeters, did actually show increased efficacy with directional stimulation or current steering. In a recent study, which I've adapted over here, they demonstrated that current steering altered the shape of the volume of tissue activated, or the VTA, and improved speech, shown here in the upper panel. The blue circle here represents the VTA from a concentric lead, and the yellow shape here represents the current steering. Adverse effects on speech can occur when you encroach on the capsule, or even when you're stimulating in medial STN. And when they moved the VTA away from medial STN, they showed that speech improved. Dyskinesias can occur with a very well-placed lead and a well-placed VTA, but it just might be too large. And in shrinking the VTA, they were able to improve dyskinesias. And this is very true in the early stages of DBS therapy. If the person gets muscle twitching or pulling, this may suggest that the VTA is encompassing the motor fibers or the internal capsule, which is usually lateral to the STN. And if the current steering moves the VTA more medial, you can also get around that adverse effect. So the use of directional leads and shorter pulse widths may improve the therapeutic window and has been shown to reduce the number of DBS lead revisions required. The downsides, however, are that the programming might become complex. And there has been evidence that there may be significant deviation of the intended angle of placement of the directional lead, which will change the orientation of the directional VTA. However, when we're able to visualize leads and the orientation of the lead on the physician tablet, this might greatly improve this. Now, we can use current steering and multiple independent current control to sculpt an irregular VTA in this larger volume of the GPI. And you can see here, this is the GPI and this is the lamina separating the GPI from the GPE. And this funny shape here is the irregular sensory motor region. We can use the directional contacts on the directional lead to sculpt out a volume of a VTA that encompasses the sensory motor region. And then we can use multiple independent current control to use a small VTA at the base of the GPI here, carefully not to encroach on the optic tract here. And also there's some evidence that the VTA encompassing the lamina and even parts of GPE may also in fact be efficacious, and one can therefore use a VTA in the most dorsal electrode using multiple independent current control. In the case of the thalamus, one can use an 8 electrode lead here, and multiple independent current control to have two VTAs, one in the thalamus proper in the VIM and VOP, and a smaller one in the dentatorubro-thalamic tract or posterior subthalamic area for optimal treatment of tremor. Now, sensing DBS systems record local field potentials directly from the DBS lead onto the implanted neurostimulator. And this is getting us closer to cardiac pacing, which can sense the heart's rhythms. We can now sense the brain rhythms. And we know that this is important because exaggerated neuronal oscillations and synchrony in the beta band, which we call the beta oscillopathy, is a marker of the hypokinetic features of Parkinson's disease. Beta band power is greatest in the sensory motor STN, and this can guide programming. And here's an example of recording local field potentials from the channels pair 0 to 1, 1 to 2, and 2 to 3 of the lead in the STN. In this power spectral density diagram, you can see that there's a spatial gradient here of beta, such that the beta power was highest across this channel pair 1 to 2. And several studies have shown that the DBS electrode closest to the site of maximal beta band power in the STN had the best outcome if used for neurostimulation. This has also been shown in the case of the directional lead, where recording local field potentials across these directional contacts showed that if the contacts that had the greatest beta band power, in this case 2 and 5, were used for active stimulation, this led to additional improvement in rigidity. Now, there's a very important feature of DBS and local field potentials, and that is that as you increase the intensity of deep brain stimulation, you attenuate or decrease the power in the beta band. And here you can see the black represents the beta band power on no DBS, and as the intensity is increased, you can see that beta band power decreases. Well, the same thing happens when you apply dopaminergic medication, and here's just the administration of 1 dose of levodopa, and as the medication kicks in, you can see this beta band power decreasing, and as the medication wears off, beta band power increases again. Now, we've been using continuous open loop DBS, which has been blind and deaf to what's happening with this biomarker in the brain. And an analogy here might be if you or your family member were being treated with for hypertension with 2 medications, both of which lowered your blood pressure, but the blood pressure was never measured, then that might lead to some adverse effects. Adaptive DBS is going to sense the beta band power, and it can then decrease its intensity as beta band power decreases with the onset of medication, and it can increase the intensity back up again as medication wears off. So summarizing a lot of studies, it's been shown that adaptive DBS is safe, tolerable, and efficacious for motor signs in Parkinson's disease, using about 50% less energy than open loop DBS, and it may reduce adverse effects of combined DBS plus medication, such as speech impairment and dyskinesias. The international pivotal ADAPT PD trial now is open, using adaptive DBS and sending the patient home on adaptive DBS, and the primary outcome will be on time without dyskinesias. Now, there's some other choices to make about the DBS system you use, and that is whether the person wants a primary cell or a rechargeable device. Primary cell devices, batteries last 3 to 5 years and require a surgery to replace them, but this is a same-day surgery and very minor, and there's no need to recharge the device. Rechargeable systems have a battery life up to 15 years. The person needs to remember to charge the system every other day or every week, because if the charge runs out, the battery will need to be replaced surgically. It's very important to have a discussion about MRI compatibility with the different systems, with the neurologist and with the neurosurgical team. Most systems are becoming or are MRI compatible, but some are only compatible with 1.5 Tesla systems. So in the near future, lead location will be available on the programming tablet, and this will use patient-specific pre- and post-operative imaging and any of the microelectrode recording data from the operating room. And the neurologist will be able to design the desired VTA on the person's anatomy and use the beta band profile to guide the choice of electrode, and use current steering and multiple independent current control to sculpt out that VTA. In the future, we believe the pulse generators will become smaller and Wi-Fi connected, which will enable them to be placed on the cranium, thus not requiring any extensions down the neck, which may reduce adverse effects and some MRI concerns. Automated algorithms will be available for the desired VTA. The use of sensing will guide the initial choice of active electrode or electrodes, and the use of adaptive DBS using neural and behavioral inputs might improve efficacy and reduce side effects. Thank you very much. I'll end there.